Today we are going to discuss care of the dying patient. While this may be an uncomfortable subject, care of the dying is an important part of the patient life cycle, and there are interventions and actions that can be taken to make the death process more comfortable for patients and their family members. Many nursing students, as well as experienced nurses, are uncomfortable caring for the dying patient. The purpose of this education is to discuss the care of the dying and to better understand the physical and psychosocial aspects involved when caring for a patient at the end of life. Death is the ultimate reality for all of us. While modern medicine has been able to delay it to an extent, it is helpful to make the process of dying pain-free for the patient and less stressful to the family and grief when death is inevitable. A nurse's duty goes beyond the immediate care of the patient and involves taking care of the family before and after bereavement. A good life is aspired by all, but providing access to a good death to all is important when possible. A comprehensive and humane approach to dying is rooted in respect for the patient's autonomy and preferences. It involves providing holistic care that addresses not just physical symptoms, but also emotional, spiritual, and social needs. The focus is on ensuring comfort, dignity, and quality of life for the patient. This approach relies on interdisciplinary teams that work together to offer comprehensive care tailored to the patient's individual values and wishes. Open communication among the patient, their family, and healthcare provider is crucial as it facilitates shared decision-making and respects the patient's desires. Ethical considerations are also paramount at the end-of-life care, ensuring that decisions are made with the patient's best interest in mind. So we'll focus on physiological responses, which are understanding the physiological response during the dying process is essential to providing effective care. Healthcare providers must recognize common symptoms such as pain, dyspnea, fatigue, or changes in consciousness. Managing these symptoms is crucial to maintaining the patient's comfort and dignity. This involves monitoring vital signs and other physiological indicators and being prepared to intervene appropriately in case of complications. Supportive measures for nutrition, hydration, and hygiene play a significant role in the patient's comfort. Additionally, healthcare providers should be aware of the patient's response to the withdrawal of treatments, ensuring that the patient remains comfortable throughout the process. Elizabeth Kubler-Ross's Stages of Grief outline the emotional journey individuals often experience when facing loss. These stages include denial, where the reality of the loss is refused; anger, marked by frustration and helplessness; bargaining, where attempts are made to negotiate for a different outcome; depression, characterized by deep sadness and withdrawal; and acceptance, where one comes to terms with loss and begins to find a new way forward. It is important to note that not everyone experiences all these stages or in the same order. Providing support through each stage is crucial, acknowledging that grief is a personal and non-linear process. Palliative care focuses on relieving the symptoms and stress associated with a serious illness. It can be provided alongside curative treatments and aim to improve quality of life for both the patient and their family. This involves pain management, emotional support, spiritual care, with personalized care plans developed in collaboration with the patient and their family. Palliative care emphasizes the importance of holistic support, addressing all aspects of patients' well-being. Coordination with other healthcare providers ensures that care is comprehensive and continuous, supporting decision-making and advanced care planning. Effective communication with the dying patient and their family is essential. This involves being honest and transparent in discussions, using clear and compassionate language, listening to the patient and the family's concerns, fears, and wishes is crucial. Providing consistent updates on the patient's condition and care plan helps manage expectations and supports informed decision-making. Offering emotional support and counseling resources can help the family cope with the situation. Encouraging family involvement in care decisions and legacy-building activities respects their role in the patient's life. Sensitivity to cultural, spiritual, and individual preferences ensure that the care provided is respectful and personalized. Nursing interventions play a vital role in end-of-life care. Administering medications to control symptoms such as pain, anxiety, and nausea is essential. Nurses monitor and adjust changes in the patient's condition, ensuring timely and appropriate interventions. Providing personal care, including bathing, feeding, and repositioning, help maintain the patient's comfort and dignity. Adjusting the environment, such as managing light and noise, can significantly enhance the patient's comfort. Facilitating family visits and legacy activities support emotional well-being. Educating the family on what to expect and how they can assist empowers them to be part of the care process. Finally, nurses must also prioritize self-care, recognizing the signs of burnout and seeking support to maintain their well-being while providing compassionate care. Palliative Care Task Force was established by the Robert Wood Johnson Foundation as an attempt to educate healthcare personnel on communication with patients at the end of their life and to establish principles to guide end-of-life care. The Last Acts campaign was the resulting work of this task force. The principles established should guide the nurse in the care of the patient that is dying. The task force describes the importance of respecting the patient's goals, preferences, and choices. This includes goals such as the ability to die at home, decisions about code status, and choices about treatment regimens such as refusal of chemotherapy or radiation, nutritional support, or IV nutrition. The task force placed a focus attending to the needs of the whole patient by addressing medical, emotional, social, and spiritual needs. As the nurse caring for the dying patient, it is important to understand not only medical but emotional and spiritual needs. The nurse may ask about cultural beliefs surrounding death and dying and perform interventions to assist in meeting the unique needs of the patient. The use of an interdisciplinary team is important in the care of patient at the end of life. This is a wonderful opportunity to discuss with patients spiritual needs and bring in pastoral care. Consulting with palliative care and hospice is also appropriate if the patient and family desires. Caring for the dying patient should include care of the family as well. Caregiver concerns should be explored and addressed. It is important to acknowledge family concerns and identify interventions. Having open, honest communication with family is an important part of the end-of-life care. The nurses should be aware that the family goes through the same stages of grief as the patient. Recognizing where the family is emotionally allows the nurse to provide care and comfort not only to the patient but to the family as well. Having a support system is crucial when caring for a patient at the end of life. Encouraging the family to care for themselves and to address their emotional needs is an important part of end-of-life care. Utilizing hospital support, such as pastoral or palliative care, can be an important tool in development of multidisciplinary care plan. I think it's important to stop here and reiterate that development of a care plan for a patient at the end of life is just as important as having a plan of care for the patient that will heal from their disease process. As nurses, it is important to recognize that while our interventions may not help the patient get better, we can have a major impact on the dying process for both the patient and the family. Okay, let's switch gears for a moment and look at some of the physiological responses in the dying patient. First, dyspnea. Dyspnea can be uncomfortable for the dying patient. The feeling of difficulty breathing can be emotionally exhausting for the patient at the end of life. Dyspnea may not be associated with physical signs such as tachypnea, diaphoresis, and cyanosis. It is important for the nurse to assess the level of dyspnea in much the same way as assessing pain using a 1 to 10 scale of difficulty breathing. The nurse can auscultate lung sounds, assess fluid balance, and assess cough and sputum. It is important to address patient and family anxiety related to dyspnea. Interventions such as repositioning, supplemental oxygen, and administration of opioids may provide relief for the patient. Pain is another physical symptom that can be associated with end of life. Pain caused by the underlying disease process can be severe for the dying patient. Assessment and treatment with analgesia is important when caring for patients. It is important to note that just because a patient may be in a nonverbal state and cannot verbalize their pain level, that pain is not present. The nurse should observe for other signs of pain, such as facial grimacing and changes in heart rate and blood pressure. Patients at the end of life may be on frequently scheduled pain medications to ensure they are comfortable. Family members may be concerned that the use of pain medication may hasten death. but families should be educated on the need for pain control and the goal of keeping the patient comfortable. Anorexia and cachexia are common in patients nearing end of life. Changes in metabolism can be associated with anorexia and cachexia. Changes in routines, such as having family meals, can also result in anorexia. As a patient nears the end of life, the desire to eat changes. This can result in changes in weight and muscle wasting. As anorexia progresses, the body will enter a catabolic state, and supplementation with gastric or IV nutrition will not increase patient's body mass. Nursing interventions related to anorexia should include offering small meals, not being concerned with eating at a specific time, adding milkshakes or other liquid supplements, scheduling meals when a family is available, and avoiding arguments about meal times. Providing proper oral care is also an important intervention for the anorexic patient. Delirium can be seen in patients near death. Periods of confusion or hallucination are not uncommon. These processes may be related to side effects of medication or underlying disease processes such as dementia or a brain tumor. These patients may be hypo or hyperactive and may have difficulty sleeping. Discussing these symptoms with the primary care provider is important as treatment with medications such as Haldol may alleviate delirium. Interventions such as massage, music therapy, gentle reorientation, and reassurance speech should be initiated for the patient suffering from delirium. In later stages of the dying process, patients may become unable to clear their secretions. This can be very disturbing to patients and families. It is important for the nurse to perform oral care to maintain the mucous membranes and performing gentle suctioning to clear secretions. Deep suctioning should be avoided as this may be uncomfortable for the patient. Repositioning may also be a benefit. Now that we have discussed some of the physiological symptoms associated with the dying patient, let's address some of the psychosocial aspects of dying. Elizabeth Kubler-Ross was a Swiss psychiatrist that introduced a five-stage model of grief in her book On Death and Dying. The five stages of grief are denial, anger, bargaining, depression, and acceptance. Denial is the first stage in the grieving process. It is an important first stage that can help one survive the loss. In the case of the dying patient and family, this may come at the time of a terminal diagnosis. Rather than becoming completely overwhelmed by grief, the patient and their family enter denial. This may include things such as the diagnosis is not true or my results must have been mixed up with someone else. It is like the body's natural defense to only being able to handle so much. Eventually, the initial shock and denial fade into anger. Anger begins when the patient begins to live in the reality of their diagnosis. It is important for the patient and family to feel anger to move on to other stages in the grieving process. During anger, patients may question their belief in their faith or question why God has let this happen to them. Anger is something for the patient to hold on to. It connects them with the reality of the situation. It is important to listen to the patient and the family in this stage. As anger dissipates, the patient moves into the bargaining phase. Bargaining is characterized by a type of false hope, and guilt can be strongly associated with bargaining. The patient may have what if feelings, such as what if I had only gone to the doctor sooner, or what if I had only followed a better diet. Patients may bargain with their God that if you take away my cancer, I will be a better person. Or family members may bargain that if my mom gets better, I'll visit more often. Depression is the next stage of the grieving process and is a commonly accepted form of grief. Depression can manifest in many forms, such as withdrawal from family and friends, lack of desire to participate in activities of enjoyment, feeling of numbness or disconnectedness, or simply not having the energy to get out of bed. This is the low point in the stages of grief prior to the final stage of acceptance. Acceptance is the final stage in grief. It's not so much an acceptance of, okay, I'm dying, but it's of, I am dying and I will be okay. Acceptance is coming to terms with the new reality of life. It is not necessarily a good thing, but I can accept it. The patient may want to interact with family and friends again or resume a hobby they love. Patients and families may revert from one stage of grief to another, and it's important to recognize where the patient and family are and offer caring support. Palliative care is comprehensive care for the patient whose disease process is not responsive to other care. This may be a cancer patient that's not responding to chemotherapy or radiation, or the patient with dementia that is progressing. The main goal of palliative care is to make a patient comfortable. This may be through the use of analgesia or other non-pharmacological pain interventions. The care of the family is also an important aspect of palliative care. Understanding the stages of grief is a way for the nurses to offer support to the patient and their family. Addressing both physiological and psychosocial needs of both the patient and the family is the hallmark of palliative care. Palliative care uses a multidisciplinary approach. In this way, it is no different than care offered to any other patient. The difference is the goal of palliative care is to provide comfort and support for the patient and their family rather than a cure. Prior to initiation of comfort care, a meeting should be held with the family to plan in advance and ideally coordinate with the interprofessional team, including clergy, social work, and respiratory therapy. Medical discussion about potential termination of life support should be led with empathetic, open support for the family, within the importance of knowing the patient's preference. Family and patient's preferences may not be the same. However, it's important to discuss this with any legal power of attorney that the family or the patient may have. The family and the patient's perception of the clinical condition, the management plan, the expected clinical course, and the outcome should be explained in detail without the use of medical jargon. The patient and family should understand the time frame for initiation of comfort care. It is at this time as well that conversations about organ donation or autopsy would be discussed with the family. It is not the primary nurse's role to discuss organ donation with the family, and this should be done by the organ donation team. Religious and spiritual support should be provided by religious leaders or priests who are familiar with the family. During these conversations, it's helpful to establish a rough timeline about the palliative extubation and termination of care, with reasonable accommodations for family requests, such as waiting for arrival of family members from a geographically distant location. Relaxing the institutional visitor policy may be needed while taking care not to compromise the privacy of the patients or their family, as well as the privacy of neighboring patients and their families. Communication with the patient and family should be respectful and honest. It is important for the nurse to be familiar with Kubler-Ross's stages of grief to be able to communicate effectively with both the patient and the family. Recognizing that a patient or family is in denial allows the nurse to better communicate. The nurse should understand the patient and family may not be ready to discuss the diagnosis or plan of care. Empowering the patient to be autonomous in their care planning is an important communication technique. Care planning should focus on the patient's need, and they should be allowed to make decisions about care at the end of life. This may be things such as restricting visitors, refusing meals, or making choices about receiving medications. Cultural beliefs can play an important role in end-of-life preferences for a patient and their family. Beliefs about what happens after death should be understood and respected. In some cultures, it's important for a window to be opened when the patient dies so their soul may leave, or in some religions, it's important for the body to be facing a certain direction at the time of death. These are important conversations to have with the patients and their families as death approaches. It is important to communicate honestly with patients and their family regarding death and dying. This is not the time to hide behind medical terminology. The nurse should assess where the patient and family are in the grieving process and present needed and factual information. With that being said, it's also important to allow the patient and family to set boundaries regarding the depth of conversations. Some patients and family may want detailed information regarding the physiological dying process, where other patients and family desire limited information. This ability to set boundaries is intertwined with where the patient and family are in the grieving process. Part of effective communication is being a good listener. In difficult conversations, one should resist the urge to avoid uncomfortable silence. Sometimes patients and families need to sit with a question before answering. You can ask if they need more time to think about their answer. Avoid the desire to give advice or tell family what you would do in their situation. Practice empathy, but avoid using phrases such as, I know how you feel. The nurse should assess not only the patient and family understanding, but their own understanding of difficult conversations. The nurse should use phrases such as, so what I hear you saying, or am I understanding this correctly? Once comfort care is initiated, pain medication infusion of usually an opioid with an analgesic drug, usually a benzodiazepine, occurs. This is followed by palliative extubation with the use of symptom control medications for control of anxiety, nausea, vomiting, dyspnea, or air hunger, oral and endotracheal secretions, fever, and with the use of artificial tears and oral hygiene measures. Depending on the patient's preference, a balance must be maintained between appropriate pain control and preservation of wakefulness. Comfort feeding and extra oxygen may be allowed. Family members are encouraged to spend time with the patient, with efforts to minimize the nursing interventions. The family is encouraged to have legacy building measures, like taking pictures, making handprints with the patient as possible. If the patient survives more than the expected duration, they may be moved to an inpatient hospice care or home hospice care with required support. After the death of the patient, the medical team members need to confirm the death, note the exact time, complete the death certificate, and any other related documents. It is humane to contact the grieving family and express the medical team's condolences. It's important for the medical staff to address and relieve their own moral and emotional stress from such clinical encounters. Informal and formal measures, including counseling, can be used to overcome this distress, as it may lead to empathy fatigue or burnout if ignored. Many nursing interventions associated with care of the dying patient. You may be addressing the physiological needs, such as administration of analgesics for pain control, gentle suctioning to control secretions, or providing ADL care. You may be providing psychosocial needs, such as spiritual care with the assistance of pastoral care, or you may be just allowing the family to discuss their fears and feelings about dying. Most important is to assist the patient with dying with grace and dignity. When I was in nursing school, I vividly remember the day my nursing practice changed. I was in clinical on the medical oncology floor and had received a report on my patient assignment for the day. I had a patient with breast cancer that had metastasized to the brain and her spine. She was not expected to survive the day. Prior to that day, I had a fix-it mindset. What can I do to fix the patient? I went to my clinical instructor and asked her what I was supposed to do for the patient if she was dying, and she told me to help her die good. I provided comfort care for this patient. I washed her face and hands. I rubbed her body with lotion. I talked with her about her life and family. I prayed with her. She did pass that day, but she was not alone, and I had made her transition as peaceful as possible. This was one of the most important lessons I learned in school and have carried with me throughout my nursing career. Compassionate care for patients at the end of life can be comforting for the patient, the family, and for you, the nurse. It is okay to grieve the loss of a patient. It is important to share your experiences with other nurses and members of the healthcare team. Death is a normal part of life, but the nurse educated about actions and interventions related to end of life can make the process easier for all of those involved.